Up guys, welcome back to another session of this lecture series, and I hope you are all fine. So for today we will be discussing in general about beta blockers. Now individual beta blockers and their role will be discussed in clinical sessions regarding specific diseases, and we have already extensively covered beta blockers when we talked about hypertension and drugs for angina. Anyway, if you want to have more knowledge on use of these beta blockers in these conditions, you may refer to those videos. Now today's session is mostly kind of a mind map session on in general concepts about beta blockers and so on. So let's see what the session holds for us. So as you are all aware, when we talk about activation of sympathetic nervous system, we talk in terms of a flight or a fight response. So whenever the body is under stress, it behaves differently than what it does under normal circumstances. So that you can appreciate here on this figure. So definitely there is going to be activation of the sympathetic nervous system, and which in turn is going to impact the release of various sympathomimetic hormones, neurotransmitters, so which will have their effects through the alpha and the beta receptors. I hope you know them. And what happens with flight and fight response are all these things. So it prepares body to tackle the stress. Okay, so that's the effect that is seen when a lot of these hormones such as adrenaline, noradrenaline and so on flows through the systems of the body. So here you can see that this body has been prepared in such a way that it will lead to a state in which the body can fight, or it will help the body to run away from the response. So this is due to activation, as I said, of the alpha and the beta receptors both together. But here we just will talk about a blockage of the beta receptors via drugs, tailor-made drugs I should say, which will only have an impact on to the beta receptors. So that will cut down the activation of the sympathetic nervous system, especially related to the beta effects. So you can see so many effects here, like for example the saliva dries out, the blood vessels in the skin just constricts, whereas the heart beats faster, and more blood supply is to the periphery because you require it for the body to run at times of stress. Breathing improves, it gives the body kind of a tunnel vision. So these all effects come about in flight or fight response. So some of these effects attribute to the beta receptors activation. So those effects will be something which will be cut down. So you will not see those effects coming down, especially due to the beta effects. At the same time, you should also remember that due to beta blockage, at times the alpha effects might exaggerate. Okay, so because that's unopposed alpha action that we talk of, so those effects might just be something which a doctor needs to look for, especially when he is giving a beta blocker. So that's a very general concept about what these beta blockers are. So today we'll be learning something on basics of that, and with the help of a mind map which we have already seen a bit of that when we talked of alpha receptor mind maps, alpha blockers mind maps. So again, if you want to learn things on alpha blockers, you might refer to my earlier lecture on mind maps with alpha receptor blockers, whatever you call it as. Okay, so let's move further. So as you know, beta blockers are tailor-made drugs, and we have three types of beta receptors. We have beta 1 receptors that's usually present on the heart. We have the beta 2 receptors that usually concentrate in and around the smooth muscles of the body. So organs which are having a lot of smooth muscles will have generally more number of beta 2 receptors, and the third are the beta 3 receptors, which are usually present on the lipid cells of the body, the fat cells of the body. Now remember that whatever this beta 1, beta 2, beta 3 receptors that we talked of, it's a relative term in biology. There's nothing like a watertight compartment. There is always overlapping of receptors that's there within each organ. So don't expect to have just the beta 1 at specific position. No, it doesn't happen that way in biology. Now we have beta blockers. Beta blockers usually will be blocking in generally the beta 1 and the beta 2. Beta 3 selectivity, I should say, is not that specific. Or we have selective beta 1 blockers. Okay, so that's the way these beta blockers has been arranged, and that is seen in this plus and plus minus signs on the respective subtypes of beta blockers. Now remember that these beta blockers are competitive antagonists. Again, if you want to learn more on competitive antagonism or about antagonism, you can refer back to my lectures in general pharmacology on antagonism. And remember that these blockers, these drugs are inverse agonist. Inverse agonist means they can bring down heart rate, for example heart rate, even in a normal individual. So they can bring out changes even in a normal setting, normal physiological setting. So that's something which refers to inverse agonist. Again, I have a lecture on inverse agonist, so people who want to find more about that can refer to my lectures in general pharmacology, clinical pharmacology on inverse agonist. So that's what these beta blockers are. So these are tailor-made drugs to block the beta receptors. And then let's move further. So the first way of classifying this beta blockers is non-selective beta blockers who have no intrinsic adrenergic activity. Okay, so these are non-selective, means these will act on all the receptors. So beta 1, beta 2, and to extent even beta 3, to extent I should say, will be blocked. So most probably the drugs under this list are propranolol. That's kind of a prototype drug for beta blockers. In addition, we also have timolol. That's a kind of a application of beta blockers for ophthalmic use, especially concerned with glaucoma. And then we have something called a satolol. That's also a non-selective beta blocker. It's basically has action onto the heart because it also has an interaction with the potassium channels on the heart, so will be used as an anti-arrhythmic agent. Now remember, these are non-selective, non-intrinsic adrenergic activity, so they don't have any intrinsic sympathomimetic or adrenergic activity of their own. Now we'll come to that, what do you mean by that intrinsic activity, but just remember for now that these are non-selective beta blockers, plus they don't have any intrinsic activity of their own. The next class of drugs in this group are the non-selective, again non-selective, but here the change is that these drugs have intrinsic adrenergic or sympathomimetic activity. Now what do you mean by intrinsic activity? Okay, because they, on one side they are blocking, but the other side they are also weak agonist. Okay, one side they are blocking, but on one side they are weak agonist of a specific subtype of beta receptor. So that is what we call it as non-selective plus with adrenergic intrinsic activity. So since they are the drugs with some minimal agonist activity or weak agonist activity, they are of help when your non-selective drugs with no intrinsic activity give you trouble in clinical therapeutics. So person who is on propranolol and who then gets a lot of bradycardia, that is decreased heart rate, he cannot tolerate this drug, that bradycardia is not tolerated by this patient, you can give that patient a drug like pindolol, which is non-selective but with intrinsic activity. It will block, but the blockage will also come with some agonist activity, weak agonist activity. Okay, so drugs like pindolol is the gold standard, I should say. So these drugs will be given when you cannot tolerate the earlier ones, And with these drugs you don't get usually bradycardia, since they are also weakly agonist drug, weakly friendly drugs. So like kind of a helpful scenario, I should say, at times of difficulty. And when you want to stop these drugs, it doesn't give rise to rebound hypertension. Okay, we'll come to that. So just for now, remember that they do not cause rebound hypertension. We have one more drug, acetabuterol, that's also in this drug. It's actually, I should say, acetabuterol is a cardioselective agent. It's not something which is non-selective, it's cardioselective. But remember that it comes with its own weak agonist activity. Anyway, I tried to put it under this list because it has its own intrinsic activity, but it's mostly a cardioselective agent. Okay, so moving further, then we have something called as cardioselective agents. Okay, so which will only block subtype of receptor. So when we talk of cardio, that means cardiac or heart cells. So these will only block mostly the receptors, subtype of beta receptors present onto the heart. So here we have the beta 1 blockers. Some people want to call them as beta 1 blockers, some people call them as cardioselective, some people call them just as cardio blockers. So whatever you want to call it as, these are cardioselective beta blockers which will block the beta 1 receptors mainly. Now that's important because, as I told you, there's always overlap, and so minimal inhibition of other subtypes may also occur and may give rise to some unwanted side effects related to this drug. So here we have atenolol, gold standard cardioselective blocker, which is long acting, once a day kind of preparation. Then we have bisoprolol, which is also a long acting, and metoprolol, that is also a cardioselective beta blocker. Now moving further from cardioselective beta blocker, we have something more. We have esmolol. Esmolol is again a cardioselective beta blocker, but remember that it's a ultra short acting beta blocker. Very important, because ultra short acting beta blockers can be of help in management of cardiac emergencies. Okay, cardioselective but with ultra short action. So you can give this drug by a parenteral route and can tackle cardiac emergencies. So is of help in management of arrhythmias. Arrhythmias is a condition where the rate of the heart, no, not rate, I should, the rhythm of the heart is not proper. So you can use that in these conditions. It can also be used post myocardial infarctions or post heart attack conditions and so on. So I don't want to go into those details, but these are the drugs which can be given for parenteral. Again, I have discussed this drug in detail when I have talked of emergency medications or emergency lecture on emergency medicine. So you can use this drug in those conditions. Then we have some more cardioselective beta blockers, but with specific activities, like we have celiprolol. That's a beta 1 blocker, but it's a beta 2 agonist. So beta 1 blocker, so cardioselective on one side, but at the other side it's a beta 2 agonist. So being a beta 2 agonist, it helps to maintain the dilatation of the smooth muscles, so is of help in management of patients who have cardiac problems, along with I should say COPD or any respiratory condition where you don't want to interfere with the dilatation of the tracheobronchial tree. So something which is good for tracheobronchial tree but still is a cardioselective blocker. And the last one is nebivolol. It's a recent addition. It releases nitric oxide along with beta 1 blockage, and it helps helpful in management of I should say post-myocardial infarction patient, hypertension. NO is a vasodilator, and nitric oxide is a vasodilator, so will cause dilatation of the vessels. So becomes an add-on to the existing beta 1 blockage. So something which is of help in management of various conditions. So something more is on drugs which will be both alpha and beta blockers. So we just talked of beta blockers, but there are few drugs which are also alpha blocking action along with the beta 1 action, beta activity. Now usually the alpha receptors which are blocked are the alpha 1. So we have labetalol, carvedilol. Labetalol is a drug of choice in cases of hypertensive urgencies and emergencies, along with carvedilol, which also can be given at cases of hypertension, also can be used in congestive heart failure and so on. Now remember that alpha blockage along with beta blockage will give rise to vasodilatation. So that's important when you want to manage conditions related to hypertension and so on, and that's why they become drug of choice, especially in hypertensive emergencies and so on. So remember that these group of drugs are very important, especially when you talk of very high grade hypertension. Again, I have talked in detail about these drugs when I talked in emergency medicines about management of hypertension and so on. So you can watch my videos. I have a separate link. You can go through my channel on drugs for these conditions, and I have discussed in detail on labetalol in that nature. So if that was, I hope that was the entire way in which you can discuss beta blockers, especially classification wise. I tried to incorporate the important points which were needed for you to know when you want to go through the classification and so on. The next in the list is the effects of beta blocking. So as I told you, it will try to inhibit all the activities of sympathomimetic neurotransmitters. So basically the action will come on to the cardiovascular system, because you know when a person is under stress, the contractions of the heart increase, the heart rate increases, the cardiac output might increase over a period of time. So you want to have a beta blockage by giving drugs. That's it will lead to a decrease in the heart rate, it will decrease in oxygen consumption of the heart, it will also decrease the contractions of the heart to an extent. Cardiac output will be also decreased initially, but over a period of time cardiac output will be increased. Now there are reasons for that. Automaticity of the heart will also be decreased, and that's why it is also used for management of I should say cardiac arrhythmias. Blood pressure also decreases. So that's the indirect effect that it causes. The blood pressure decreases basically due to the decrease in the renin release by the kidneys. It's also due to the lack of central stimulation which occurs which is inhibited by the beta blockers. So that's the reason that you get a decrease in the blood pressure and not a rise in the blood pressure. And decrease in the blood pressure happens over a period of time, and that doesn't happen suddenly after giving beta blockers. Now remember that do not stop beta blockers suddenly, because if you stop beta blockers suddenly, beta receptors become super sensitive to the presence of minute amounts of neurotransmitters, and it can give rise to hypertensive issues with the patient. So do not stop it suddenly. You need to taper doses of the patients when we are giving a beta blocker and want to just decrease it. So these were, in short, I should say, are not discussed in detail, but the specific details about its effect I have talked when I talked about hypertension videos and videos on angina. So that's how their effects on CVS are seen. The next, it decreases intraocular tension in the eye, and you can see an increase in the peripheral vascular resistance, because peripheral vascular resistance usually will increase because dilatation is maintained by the beta receptors. You block them, you are increasing the resistance, because there won't be any dilatation, there will be just the constriction. Anyway, vessels become tolerant to the effects of these I should say these drugs over a period of time, and eventually you see a decrease in the blood pressure. So that's how you see that blood pressure effect also coming, but initially there is an increase in the PVD. And also, so one of the reasons that you shouldn't be giving these drugs, especially for patients with vasospastic conditions, peripheral arterial conditions, PVD, peripheral vascular disease conditions, not to give these drugs, because they can increase uh, the chances of patients suffering from these diseases. So lipid levels will rise, so there will be disturbance in lipid levels, as well as blood sugar levels also will be disturbed if you are trying to give beta blockers. Bronchial narrowing will occur, especially in respiratory conditions. So these three conditions exactly you want to be aware of when you are trying to give a beta blocker to the individual. Now remember that whenever there is a flight and a fight response, your body requires energy. So your neurotransmitters, so sympathomimetic neurotransmitters, will try to increase the blood sugar, will try to break down the lipid level. So you're trying to give you beta blocker, you're trying to restrict these two processes, which will eventually give rise to disturbance in blood sugar and a rise in the lipid levels. Of course, you're trying to block the beta 2 receptors, which are primarily there for relaxation of the smooth muscles. So patients who are already prone to respiratory conditions like COPD or bronchial asthma might suffer from ACAT of bronchial narrowing. So you need to be careful in all these three conditions whether you want to start a beta blocker or not. So want to be careful on these issues. Of course, it gives rise to, if you're taking this drug, it gives to easy fatigability of the muscles, basically due to vasoconstriction that occurs in the periphery, and also due to disturbance of the blood sugar levels that occurs. So energy levels are not well maintained. These drugs do not cross the blood-brain barrier, but a few of them might cross to a lesser extent. So some people suffer from confusion, dizziness, wild dreams, nightmares, and so on. Cold extremities, that basically occurs due to beta 2 receptor blockage that gives rise to vasodilatation. So blockade, vasoconstriction. So I already discussed with you on those points. And sexual disturbances are also observed, especially with the male individuals. Mostly these drugs have high first pass metabolism, especially propranolol, I should say, and it is also extensively plasma protein bound. If you want to look at the uses of beta blockers, then we use them in hypertension, essential hypertension. It's one of the drug of choice for mild to moderate hypertensive individuals, but need to look at the other factors and then want to start the patient on these drugs. Anyway, I'm just giving here undergraduate talk, so let's define it to just hypertension. We can also use beta blockers, or in fact we use beta blockers for prophylaxis in angina pectoris, or we also give them these drugs in post myocardial infarction patient to limit the infarct size and to improve the survival rate, especially if the cardiac output is good and the heart rate is good. We want to give this drug so that the bridge benefits of these drugs can be achieved. Anyway, there are few contraindications where you do not want to use these drugs, especially in heart myocardial infarction with heart blocks, very less heart rate, and so on, where you do not want to use these drugs. But anyway, not going into those details. Just remember that with good cardiac output, with good heart rate, really about 60 plus, we would like to give these agents to limit the infarct size and also want to prevent any further attacks of angina, and it decreases the oxygen consumption demand for the heart. These drugs are also used in congestive cardiac failure. Now remember that these drugs are sympatholytic drugs, so it will try to give the heart some rest, as well as try to prevent certain remodeling that occurs, pathological remodeling that occurs, especially in patients of congestive cardiac failure. So the overall survival rate in patients with CCF is improved over a period of time. Now this effect may not be seen on the first day, but if you are taking these drugs over a period of time, definitely the survival rate will increase. But you want to have a good cardiac output before you want to start these drugs. So that's the requirement: good heart rate, good cardiac output, and so on. Now there are various schools of thoughts on whether to want to start a beta blocker or not, but that's not the case at least at undergraduate level. So try to remember that They are sympatholytic in nature, so they protect the heart cells, they prevent remodeling, and they improve the overall survival rate of the heart, but provided initially you have a good heart rate and a good cardiac output. We also use these drugs, especially like esmolol, which is short acting, or satolol, which has a potassium ion action on the heart for cardiac arrhythmias, supraventricular tachycardias, or I should say conditions where you have a lot of adrenaline in the body and which is giving rise to arrhythmias. You want to use beta blockers. So especially intraoperative cardiac arrhythmias, you want to use beta blockers, and so on. So these are the conditions. Atrial flutter fibrillation, to control the ventricular rate, you want to use a beta blocker. So these are few conditions where you want to use beta blockers as far as CVS conditions are concerned. We use beta blockers like timolol and related drugs in glaucoma, especially wide angle glaucoma, because these drugs are something which will give rise to decrease in the formation of aqueous humor. So that's one of the reasons that you want to use these drugs in these conditions. These drugs are also used in cases like anxiety disorders, panic attacks, tremors, essential tremors. You want to use these drugs because these are actions which are mediated by the beta receptors, especially the beta 2 receptors. Thyrotoxicosis, again a condition where there is a lot of sympathetic activity, so you want to use these drugs to put the body at rest. A few drugs like propranolol are good drugs as far as migraine prophylaxis is concerned. So these are in short uses of beta blockers. Of course there are a few other uses, but I don't want to go into those details right now. Beta blockers should not be given along with calcium channel blockers, because these two agents have a negative impact on the heart. So try to avoid them, because that can give rise to extensive bradycardias, or even can give rise to blocks in the heart. So try not to give these drugs together. You are not supposed to be giving beta blockers along with nasal decongestants. So nasal decongestants are a common drugs which are alpha agonist activity. So you want to give beta blockers to these agents, and alpha activity will be exaggerated. So the patients who are hypertensive, who take nasal decongestants for cold cough fever, already taking a beta blocker, you can see certain hypertensive issues with these individuals. So try to avoid them with any cough cold mixtures, especially with patients like hypertension patients or patients with any cardiac problems. Try not to give these combinations together. Anyway, I should say nasal decongestant itself has so many issues that you should be careful while administering these drugs. The benefit is far less as compared to the risk associated, especially with nasal decongestants. Try not to give beta blockers with insulin and oral hypoglycemic agents. Okay, beta blockers, as I said to you, will block the beta receptors. And that's a very basic and very clinical interaction that occurs here. Beta blockers, if you are trying to give it in diabetes, we discussed that point, that it will disturb the blood sugar levels. But what happens exactly is that beta blockers will try to mask the signs of hypoglycemia. Now remember, hypoglycemia is the condition where the blood sugar goes down. Now it's kind of a war situation for the body. Okay, think about a body where the blood sugars are very down. So the sympathetic activity in that case will try to give out signals to the individual that the blood sugar is very low and he need to eat something, okay, to get his blood sugar back to normal. So those symptoms will be tachycardia, sweating, confusion, dizziness, and so on. Now some of these effects are mediated through the beta action. Now if the patient is taking a beta receptor blocker, these warning signals will never come up in hypoglycemia. So then these warning signals are very important, because that will give signal to the patient to eat something. If these warning signals don't come up, then the patient might remain in hypoglycemia, and that might be detrimental to the individual, especially with the brain function. So try to avoid beta blockers in diabetes, that's for sure. Anyway, you can be using cardioselective beta blocker. That also depends upon I should say, the blood sugar maintenance of that patient over a period of time. Now, there are various schools of thoughts on whether you want to start, whether you want to stop, or whether you want to change to some other agent. But that's not something at this level, so better stick to as a no to beta blockers, especially with diabetes, especially non-selective ones. Better try to avoid. So beta blockers and insulin and oral hypoglycemic agents, try not to mix all these drugs, because it's not going to help patient, and it can bring rise to a lot of misery for the individuals. So that's a no. And as I said, do not stop beta blockers abruptly, because you stop beta blockers abruptly, the receptors will become super sensitive to even minute quantities of sympathomimetic amines, and it can trigger hypertensive crisis for the individuals. Better try to taper it over a period of week or two before stopping or even changing these agents to some other new therapies. You need to be careful in patients who are having Raynaud's phenomena, or those who suffer from peripheral vascular diseases. I already explained to you. You need to be careful in patients with high lipid levels, with dearranged glucose levels like diabetes and so on, and in persons with respiratory conditions like bronchial asthma and COPD. Now, that's a relative contraindication. There are reports saying that you can use them, and we use them actually, I should say, but I still say that need to be careful in these individuals. So that is a complete mind map on beta blockers. I tried to cover up most of the points related to beta activity within the body. Going further, these are two cases which were published I should say not recently, a few years back, and one of the famous journals on the and the title said something on beta blockers. So there are two cases, and you need to decide for yourself. You need to go through the literature and then want to answer these questions, whether you want to put the patient on beta blockers or not. So the first case says that is a 70-year-old man who was diagnosed with a ST segment elevation anterior walled MI, who underwent primary percutaneous coronary intervention with stent placement. After 3 days, the left ventricular ejection fraction was 35. He was prescribed aspirin, clopidogrel, and ACE inhibitor, and also a statin. Do you want to use a beta blocker? You need to answer this question. I'll be happy if you comment back to me on your views on this case. The next case is about a 67-year-old woman with history of hypertension who was diagnosed with non-ST elevation MI. The left ventricular ejection fraction was 50%. She was prescribed nitrates, aspirin, ACE inhibitor, and a statin. Do you want to use a beta blocker in this case? You need to decide, and as I said, you can always comment back and we can have a discussion on whether to want to use a beta blocker or not. Now, these two cases are of course not something that you will encounter as far as your basic knowledge of beta blockers is concerned, but taking it back to the therapeutics, these all things matter a lot. So need to search on that and need to give an answer. I'll be happy to discuss with you these points on further course of use of beta blockers in clinical therapeutics. I hope you like this session. Thank you, and do subscribe to this channel.